So now in antifungal drugs, let's see the classification first. Okay, so what is the classification? Now in the classification, the first category of drugs that we have are polyene, and in this the drugs that we have are Amphotericin B and nystatin and hemicin. Their site of action is the membrane. Okay, and what do? They basically bind to ergosterol and form pores in the membrane, and through the pores the bacterial content, the fungal content that gets out, and the fungus is died. Then anti-metabolite. So in anti-metabolite we have 5-flucytosine. This basically acts in the nucleus and it inhibits the nucleic acid synthesis. Okay, then next category is heterocyclic benzofurans, and these drugs include greaseprolvin. They're present in the nucleus, they also act in the nucleus, and it basically inhibits the spindle formation, right? So it disrupts the microtubule function by inhibiting the spindle formation. The next category is azoles. Now in azoles we have triazoles and we have imidazoles. So in triazoles, the drugs that we have are fluconazole, then itraconazole, voriconazole, posaconazole, turconazole, right? They act in the membrane and they basically inhibit the enzyme. They inhibit the formation of ergosterol. And how? By inhibiting the enzyme, that is 14-alpha demethylase. Okay, this is the action of azoles. In imidazoles, the drugs that we have are ketoconazole, clotrimazole, miconazole, and econazole. These drugs are also present in the membranes only. And how do they act? These drugs, they also act in the same manner. The next category is allyl amines. The drugs that we have in this category are terbinafine, butinafine, and naftifine. Okay, and these drugs are membranes, and what is their mechanism of action? They inhibit the enzyme squalene epoxide, and thereby they cause accumulation of toxic squalene. Okay, this is their mechanism of action. Then sixth we have echinocandins. Echinocandins में the drugs that we have are caspofungin, then micafungin, and we have anidulafungin. Okay, these drugs, they act on the cell wall and they inhibit the beta-1,3 glycan. So they inhibit the formation of cell wall. So these are the drugs, antifungal drugs, starting from polyenes, which bind to ergosterol, form the pores, antimetabolites, which inhibit the nucleic acid synthesis, greaseprolvin, which inhibits the spindle formation, azoles, which inhibit the formation of ergosterol, allyl amines, which inhibit the enzyme squalene epoxide and cause accumulation of toxic squalene, and echinocandins, which inhibit the beta-1 glycan, right? So now let's take these drugs one by one. So the first drug that we take is the most read ones, that is Amphotericin B. Now Amphotericin B is a polyene antibiotic similar to nystatin. It is not absorbed orally, so given by slow IV infusion. It is widely distributed except in the CNS. I've told it binds to ergosterol and form pores in the membrane. It has got the widest antifungal spectrum. Okay, except किसके ऊपर एक्ट नहीं करती है? Pseudo Aleuria poides, right, and Fusarium. Otherwise, it is the drug of choice for most systemic fungal infections. Okay, so it is the drug of choice for cryptococcal meningitis, mucormycosis, and sporothrix. It can be used intrathecally in fungal meningitis. and can be used locally for corneal ulcers and keratitis, right? Then infusion related reactions seen, and you can give antihistaminics or glucocorticoids for the same. Then dose limiting toxicity is nephrotoxicity, which is manifested as renal tubular acidosis, hypokalemia and hypomagnesemia. Okay? So if you, how can you avoid by giving intravenous normal saline before giving Amphotericin B. So saline loading, it is called as saline loading, will reduce the nephrotoxicity. It can also result in anemia. Now intrathecal injections, हमने यहाँ बोले थे, intrathecal injections can result in seizures also, that is neurological damage. Then one important feature that it is not absorbed orally, so then इसके liposomal वो बनाए गए, liposomal Amphotericin B या colloidal dispersion and lipid complex. These are lipid preparations of Amphotericin B, and they reduce the accumulation in kidney, and so reduced nephrotoxicity, right? So this is about Amphotericin B. Coming next to antimetabolite, that is 5-flucytosine. So now in 5-flucytosine, we know this is a pyrimidine analog, right? And it is given orally. It is basically converted by cytosine deaminase to 5-fluorouracil, and which is an inhibitor of thymidylate synthase, right? It is used synergistically with Amphotericin B. इसकी toxicities include करती हैं bone marrow suppression, alopecia. So these are the toxicities of flucytosine. Coming to the next category of drugs, that is azoles. Now azoles, as we have seen, they have got two categories, triazoles and imidazoles, right? Now mechanism of action is that they inhibit the enzyme 14-alpha demethylase and inhibit formation of aldosterone, which plays a very important role in the formation of the cell membrane. So because of this, they are not used. Now azoles have opposite action to Amphotericin B, so they are not used together because they inhibit the formation of aldosterone and they need aldosterone to produce action. Okay, coming to the now individual azoles, let's see, because they are the important drugs. So in this, ketoconazole is there. Ketoconazole, it has got a narrow spectrum and a lot of adverse drug reactions, so now it is rarely used. Okay, secondly, it also inhibits the cytochrome P450 enzymes, so then they cause a lot of drug interactions. So these drugs are again not used. Inhibit cytochrome P450 with other drugs are voriconazole, fluconazole and itraconazole, right? So in interaction, and this can even result in gynecomastia and infertility because it causes decreased formation of gonadal hormones. Okay, then the next drug that we have is fluconazole. So fluconazole का क्या है? Fluconazole has got maximum oral bioavailability and also CNS penetration, right? It is the drug of choice for candidiasis, cryptococcosis and coccidioids, right? Then in cryptococcal meningitis, fluconazole is used for the maintenance therapy after induction with Amphotericin B and 5-flucytosine. This is in the cryptococcal meningitis. So fluconazole is the drug of choices in all the C's: candidiasis, cryptococcosis and coccidioidomycosis, right? The next drug that we have is itraconazole. Itraconazole is basically the drug of choice for blastomycosis. it is non-meningeal. Then it is used in histoplasmosis, coccidioidomycosis, and paracoccidioido, and also sporotrichosis. Sporotrichosis, my earlier potassium iodide was used in sporotrichosis. Then its entry in CNS is limited, so it is not used in CNS meningitis, fungal infections. Fluconazole is the drug of choice for prophylaxis of febrile neutropenia, whereas voriconazole is drug of choice for treatment part, right? The next drug that we have is voriconazole. Now voriconazole is the drug having the widest antifungal spectrum among azoles. So it acts on all except mucormycosis and sporotrichosis, right? It is the drug of choice for invasive aspergillosis, then fusarium and pseudosporium. Okay. Adverse reactions, it causes diarrhea, rash, and hepatotoxicity. It is implicated in prolonging QT interval. It also causes visual disturbances like blurred vision, then color alteration, and photophobia. Long-term use is associated with multi-step phototoxic processes, which include phototoxic processes followed by, it can result in actinic keratosis and squamous cell carcinoma, right? Then we have posaconazole. This is the only azole used in mucormycosis. And there is one drug, isavuconazole. This is an orphan drug, and this is also used for treatment of aspergillosis and mucormycosis. Okay, so this was all about the azoles. The next category that we have is echinocandins. Now in echinocandins we have the drugs caspofungin, micafungin, and anidulafungin. They are used intravenously, and they inhibit the beta-3 glycan, which is a component of fungal cell wall, and it is approved for invasive aspergillosis, which is not responding to Amphotericin B or voriconazole. Okay. This is quite non-toxic. So caspofungin is mainly used in aspergillosis and also used in candida, right? So this is echinocandin. Then there is a new drug which is called as ivermectin. Okay. Now this is a new drug similar in mechanism to echinocandins, that is, it also inhibits the cell wall formation, and it is effective orally, and it is used in vulvo-vaginal candidiasis. Okay. This is also used in aspergillosis and fungal strains which are not responding to echinocandins. Okay. Then the next category of drugs, systemic drugs for superficial infections. In this we have greaseprevir. So greaseprevir is used orally, and absorption is increased by fatty meal, right? It gets distributed to stratum corneum and interferes with microtubule formation. So formation of spindles is inhibited. The main fungus it acts against is dermatophytes. So it is used in the dermatophytosis of skin and hair. That is also called as tinea infections. Okay. because it is getting concentrated in keratin, right? Adverse effects may, first of all, it causes disulfiram like reaction. Secondly, it causes GI disturbance, photosensitivity, and also liver dysfunction, right? Then azoles are also used for the superficial infection. In this we have ketoconazole, fluconazole, itraconazole can be used orally for superficial infections, not voriconazole. Voriconazole doesn't have any action on the superficial infections. Third is allyl amines. Now allyl amines में जो drugs आती हैं, they are terbinafine, right, naftifin and butanafine. Now these are fungicidal agents and they inhibit the squalene epoxide. So by inhibiting the squalene epoxide, they cause accumulation of toxic squalene, right? And adverse effects में अगर हम बात करें, they mainly cause GI upset, right? Then coming to the drugs, the antifungal drugs, topical drugs for superficial fungal infections. So topical drugs for superficial fungal infections में the drugs that we have are polyene. इसमें आता है nystatin. This is used for for oral candida infections and oral for GI fungal infections, right? Then we have imidazoles. Imidazole में we have clotrimazole, miconazole, iconazole, ketoconazole, lot many drugs, tioconazole, butaconazole, oxyconazole, sertaconazole. So these are all imidazoles. Then we have allylamines, in which we have just seen terbinafine and butanafine and naftifine. So they are also used in topical fungal infections. Next we have oxaboroles, in which we have tavaborole. Then another fungal infection, fungal drug is cyclopyroxolamine. This is also used topically. Then benzoic acid with salicylic acid. This is called as Whitfield's ointment. Okay. Then tolnaftate, andecyclinic acid, and haloprogen. So these are some topically used antifungal agents also. So with this we finish the antifungal agents. Now next we discuss the drugs used in amoebiasis, so antiprotozoals and anti-helminthic. Okay, let's see them. The next category of drugs that we have to see are anti-amoebic drugs. Now in anti-amoebic drugs, the classification, if we see, so we have drugs which are, there are two types of drugs, luminal and extraluminal. Okay, so extraluminal drugs, the drugs which are only tissue amoebocytes or tissue cytocytes, they are chloroquine. Okay, in luminal which we have, that means they are acting only in the colon, intestine. So we have diloxamide furoate, then paromomycin, iodoquinol, quinodochlor, and tetracycline. And then there are drugs which are luminal plus extraluminal. In this we have the drugs which belong to nitroimidazole group. So in this the drugs that we have are metronidazole, then tinidazole, then secnidazole, and ornidazole. Okay. Apart from that we also have emetin and dihydroemetin. Right. So the most important category in this chapter is basically the nitroimidazoles. So let's take them first. Nitroimidazoles. In this we have metronidazole, tinidazole, secnidazole, ornidazole. Now these drugs, they are effective orally as well as IV. They are eliminated by liver metabolism, hepatic metabolism, and the nitro group, it gets activated to produce cytotoxic products that damage the DNA. Then important thing, this is the drug of choice for intestinal wall disease and amoebic liver abscess. Okay. This is the drug of choice in intestinal wall disease and amoebic liver abscess. Apart from that, it is combined with a luminal amoebicide for these conditions. It is not a very good drug for luminal amoebiasis because see, luminal amoebiasis mein it is usually completely absorbed in the proximal intestine, completely absorbed in proximal, so it is not really reaching the distal intestine and the colon. Then it is also the drug of choice for other protozoal infections like trichomoniasis, giardiasis, bacterial vaginosis, and also pseudomembranous enterocolitis, which is caused by Clostridium difficile. It is also the drug of choice for anaerobic infections like bacteroids and Clostridium, and also for H. pylori, right? The adverse effects caused by metronidazole are usually nausea, vomiting, metallic taste in the mouth, and also cramps, abdominal cramps. Then it causes discoloration of the urine, right? It causes dizziness and leukopenia. It can also cause seizures. Then, opportunistic fungal infections can occur. Most important is that it causes disulfiram-like reaction with alcohol. Then it has got a lot of drug interactions, so it increases the action of warfarin, right? Now, out of this, secnidazole has the longest half-life. So secnidazole is basically given a single dose also. So these are the various features about the nitroimidazoles. The next drug in this category is diloxanide furoate. Now diloxanide furoate is basically a luminal amoebicide. So it is the drug of choice for asymptomatic intestinal amoebiasis. Okay, and it is used with tissue amoebicides for extraintestinal action also. Diloxanide is the drug of choice for carriers. Okay, it is adverse effect may it causes flatulence. So these are the important features about diloxanide furoate. Then the next category is emetin and dihydroemetin. Now these drugs, they act by inhibiting the protein synthesis, and they are used parenterally in severe hepatic amoebiasis, right? Toxicity, it causes emesis, muscle weakness, and cardiotoxicity. It is very rarely used now, so it is not something of clinical importance. Then the next drug that we have is iodoquinol and quinidochlor. Now these drugs are basically again luminal amoebicide. They have a lot of side effects. What are the side effects? They cause thyroid enlargement. They cause peripheral neuropathy. Then they can also cause various defects in the eye, and they are responsible for causing subacute myelooptic neuropathy. So remember, quinidochlor causes SMON, subacute myelooptic neuropathy. Then next drug is paromomycin. Now paromomycin is basically an aminoglycoside, okay, and it is used as luminal amoebicide. This drug also is used in cryptosporidiosis in AIDS patients, and it is approved for use in Kala Azar also. Okay, so this is paromomycin. Then the other drug that we have is nitazoxanide. Now this nitazoxanide is basically a prodrug and is converted to dizoxanide. It basically inhibits the pyruvate ferrodoxin oxidoreductase enzyme, that is called as PFOR, and this is essential for energy metabolism in anaerobic organisms. Okay, it has good activity against Cryptosporidium parvum. It also has activity against Entamoeba histolytica, Trichomonas, Ascaris, H, Nana, and Giardia, which is not responding to metronidazole. But it is basically approved only for giardiasis and cryptosporidiosis. Okay, so this was about the treatment for amoebiasis. Next, let's take the treatment for trypanosomiasis, leishmaniasis. Coming to other antiprotozoal infections, so here we have trypanosomiasis. Now, trypanosomiasis is of two types. It is African and it is South American. Right? Now, South American trypanosomiasis is caused by Trypanosoma cruzi and it is called as Chagas disease. Okay? And African trypanosomiasis is caused by Trypanosoma gambiense and Trypanosoma rhodensiensis. Then it is called as sleeping sickness. Okay? Now, what is the drug which is available for the treatment? The first drug is pentamidine. Now, what is that in pentamidine? Pentamidine mechanism of action is not clear, but it basically interferes with nucleic acid metabolism. Okay? It is effective against early hemolymphatic stages of sleeping sickness. It does not cross blood-brain barrier, so it is not effective in late CNS stages. Right? So pentamidine is basically used in the prophylaxis by aerosol and treatment by IV of pneumocystis jirovecii pneumonia and treatment of Kala Azar. So this is what the drug pentamidine is used for. There are some side effects. What are the side effects? It can result in respiratory abnormalities, hypertension, hyperglycemia. Right? The next drug in this category that we have is melarsoprol. Now, what is melarsoprol? This is basically an arsenical and it is the drug of choice in late stages of African trypanosomiasis. Okay? The third drug that we have, other drugs, I'll say. In other drugs, we have benznidazole. This is the drug of choice in Chagas disease. Right? Then we have another drug that is called as suramin. Now, what is the suramin? Suramin is the drug of choice for early hemolymphatic stage of African trypanosomiasis. It is also used as an alternative to ivermectin in onchocerciasis. Right? Then there's one more drug, eflornithine. This is used in trypanosomiasis. Also used in women to delay the regrowth of facial hair. Okay, so this is about trypanosomiasis. In early hemolymphatic stages, suramin is used. In late African trypanosomiasis, melarsoprol is used, and in Chagas disease, benznidazole is used. Otherwise, we also have pentamidine, which is used in the early hemolymphatic stages of sleeping sickness. The next next disease that we look into is the drugs for leishmaniasis. Okay, so in leishmaniasis, we have leishmaniasis of three types. It can be visceral, which is called as Kala Azar. It can be cutaneous, and it can be mucocutaneous. Okay. Diagnosis of leishmaniasis is done by positive RK39 dipstick test. Okay. The drug of choice for visceral leishmaniasis is liposomal Amphotericin B. Okay. So this is the drug of choice for visceral leishmaniasis. Then there's another drug, sodium gluconate. This is basically a pentavalent ammonium compound. This is used, most commonly used treatment in all forms, cutaneous, mucocutaneous and visceral. But this is administered parenterally only. And second, this is a cardiotoxic drug. So what it does is it increases the QT interval. Right? Alternative treatment में we have pentamidine, we have miltefosine, and we have sitamaquine. Right? These two drugs can be given orally also, Then paromomycin. This drug also is approved for the treatment of Kala Azar. And the drug miltefosine, it is basically the drug of choice for post Kala Azar dermal leishmaniasis. Okay. Then next है fluconazole or metronidazole, is used for cutaneous lesions. Then Amphotericin B is used for mucocutaneous lesions. Right. Other drugs that can be used are ketoconazole, naproxen, and allopurinol. So drug of choice for Kala Azar is liposomal amphotericin B. Drug of choice for dermal leishmaniasis is miltefosine. Most commonly used drug is sodium stearogluconate. This is about leishmaniasis. Let's go to the helminthic treatment, anti-helminthic drugs. So now coming to the anti-helminthic. Now in this we have nematodes. Nematodes में आते हैं हमारे पास roundworm, that is ascaris, hookworm, pinworm, threadworm, filarial, that is Vaucularia, Bancrofti, Broogie, Malai, right? Then we have whipworm, Trichinea worm, and uniworm. Okay, I'm not written worm, but I'll write because otherwise it will. Then we have second category is trematode. Okay, now what are trematodes? In this we have blood fluke, which is called as schistosoma, right? Schistosoma mansoni होता है, schistosoma japonicum होता है, and schistosoma hematobium होता है. Then we have lung fluke, and we have liver fluke. Liver fluke is also called as fasciola hepatica, right? And the third category we have is cystode. In cystode we have pork tapeworm, which is called as Pinia solium. Then we have beef tapeworm, then fish tapeworm, then dog tapeworm, and we have dwarf tapeworm. Okay, so these are the various helminth, nematode, trematodes, and cystode. Let us see their treatment also one by one. So classification, let's see the classification of anti-helminthic drugs. The first category, the drugs which inhibit the polymerization of tubulins. इसमें आते हैं albendazole, mebendazole, thiobendazole, and praziquantel. The second category is drugs which cause spastic paralysis of the worm. These are basically nicotinic receptor agonist, right? So in this we have pyrantel, palmoate, and levamisole, right? Then the third category is drugs which cause flaccid paralysis. These are GABA A agonist. So in this we have piperazine and ivermectin, right? Fourth category is drugs which alter the microfilarial membrane. So that is diethyl carbamazine, that is DEC, right? Then we have drugs which cause uncoupling of oxidative phosphorylation. So drugs which cause uncoupling of oxidative phosphorylation, may we have niclosamide and methionine. Okay, and the sixth and the last category is drugs which cause influx of calcium. In this we have praziquantel, right? So this is the classification of the anti-helminthic drug. Now let us take them one by one. सबसे पहले अगर मैं बात करूँ albendazole, mebendazole, and pyrantel, they have wide anti-helminth spectrum, right? Next, albendazole is the drug of choice for treatment of all nematode infestation, including cutaneous larva migrans, visceral larva migrans, that is toxoplasmosis, It is also used in neurocysticercosis, except enterobius, used in Burkhardia and Brugia also, where we have used DEC also, used in onchocerciasis and strongyloids infection, in which ivermectin is also used, and it is also used in ranunculus, in which metronidazole can also be used. Okay. The next point, praziquantel is the drug of choice for all trematode and cystode infection except fasciola hepatica. Fasciola hepatica में we use albendazole. Antihelminthic disease में we use albendazole. Next is that high dose albendazole can be used for more than 3 months, like it is used in hydatid disease, and this can result in hepatotoxicity, right? Then diethylcarbamazine, that is DEC, it acts on both microfilaria and adult, while ivermectin, it acts only on microfilaria. Okay. Then there is a disease, onchocerciasis. This is also known as river blindness, and this is treated by ivermectin. Okay. Ivermectin is contraindicated in children below 5 years of age. Then next है niclosamide is used for most of the cystode. It is, however, superseded by praziquantel, right? Next है ivermectin. Ivermectin is also approved recently for treatment of topical inflammatory lesions of rosacea. Then there is a new drug. The name is moxibectin. This is approved for the treatment of onchocerciasis. This basically acts by GABA and glutamic channels. So if you see the drugs acting on helminths, we have albendazole, mebendazole, parental. They have a wide spectrum. Albendazole is drug of choice in nematode infections, also a lot of other infections. Then praziquantel is the drug of choice for all trematode and cystode infections except fasciola, in which triclarbendazole is used. Right? In hydatid disease, we use albendazole. Albendazole, if used for more than 3 months, can result in hepatotoxicity. DEC is used for filariasis. Onchocerciasis is used for river blindness. Ivermectin is contraindicated in children below 5 years and also approved for treatment of rosacea. Niclosamide is used for cystode infection. However, it is superseded by praziquantel. So with this, we finish the helminthic treatment. Now, what is remaining is antiviral and antimalarial.